regional anesthesia, ultrasound-guided regional anesthesia, is not only good practice, it's actually a standard practice. So it's definitely something that we should be doing more and more. But when should we be using that type of local anesthesia compared to another one? Making here is kind of some inclusion and exclusion criteria. So inclusion would be any pain control that is needed for a region that is innervated by a particular nerve or a group of nerves, meaning that with one or maybe a couple of pokes, you can reach these nerves, put some anesthetic around, and then acquire a good local anesthesia. But there is a couple of exclusions that we should all be knowing. So first of all, if there is a risk of compartment syndrome, because for sure, if you stop the pain, then the patient is not going to be able to tell you if the pain is increasing, and so you're not going to be able to tell when the patient is going into a compartment syndrome. If the patient has had history of allergic reaction to local anesthetic, if there is an infection at the site of injection, if the patient has a coagulopathy, that one is a kind of relative exclusion though. Some literature say that it's still safe to use local anesthesia. And if you're unable to perform a neurovascular exam for any reason, either the patient is in altered mental status due to the trauma that just happened, or the patient has any comorbidities that would put him in a state where he cannot really tell you. So that is also something that is important for us. Then where can you do blocks? So here from that paper that was done by a PEM fellow working in Bronx in New York, describing very well all the indications for nerve blocks in pediatrics. So there is a couple of places where you can do that actually. So going in a kind of head to toe setting, first you can do the inferior orbital nerve block that is just underneath your eye, and it's going to actually give you a good anesthesia of the cheek and the upper lip. Then you have the supraorbital and supratrochlear nerve block. So just in one spot, which is the middle part of your eyebrow, you get these two nerves together, and that gives you a good anesthesia of the lateral and medial forehead. The mental block, which will give you an anesthesia of the chin and the lower lip. The great auricular nerve block, so that one you find more in the neck area, and it is to, if you have any procedure to do on the external ear. For these ones, you don't really need as much the ultrasound. Wrist block, so for that you're going to target the median, the ulnar, and or the radial nerve for hand injuries. And you can also, they were talking that paper more of wrist block, but we are going to talk about the forearm blocks because you can actually reach them more easily in mid forearm rather than really in the wrist location. Block, if you want to catch your forearm a little bit better. And then you can even go to the axillary region so that you can get the brachial plexus block, which blocks, so still the same nerves, median, ulnar, and radial, but that would actually give you a better blockade of the motor functions as well as the sensory fibers. And then for the leg, go to the femoral block. So that one is one that we're going to talk about in a bit more details. You can go around the ankle as well to get some either ankle or foot coverage. And then they're also talking about the penile block. That would be for any procedure like paraphimosis, for example. Yeah, sure. That we would never do in the emergency. Who knows? I mean, maybe you do that in Israel, but we definitely don't do that in Switzerland. Yeah, I know. I'm definitely being very mean to this child. But it's for good reasons, right?
Actually, if you do it in the right, probably going to save a lot of money because otherwise,
true.
That's another. Yes.
What about the complications? So complications that we should know about for sure is intravascular injection. That is very rare. And if you use your ultrasound, usually you decreases the risk. But it's something that can be dangerous. So rare meaning 7.5 for 10,000 patients. Manifest first as a kind of numbness and tingling or a metallic taste, sometimes tinnitus, nausea, or dizziness. But what you definitely fear are seizures, cardiac arrest, and respiratory failure. There is a treatment for that, which is intralipids. So any emergency department doing nerve blocks should have intralipids in the department. It doesn't have to be at the bedside, but it should definitely be in the department. And then you should probably have the patient on a monitor during your nerve block to be safe. But if you do your procedure correctly, meaning that you always see the tip of your needle while you inject, and you make sure that you do not get any blood back, it shouldn't happen. The next complication is intraneural injection, also something that if you use the ultrasound, you shouldn't really get because you know where you are and where you inject. So it's pretty rare, 1.9 for 10,000 procedures. The patient would have pain when you do the procedure and then could get nerve injury inducing neuropraxia, meaning that the nerve is not going to work as it was. So some either paresthesia or paralysia could appear. It's something that is usually not long lasting. It usually lasts for up to 3 months and just recover by itself. Other complications could be allergic reaction. So just ask the patient if they have any. Locally for sure, and infection, but that is really very rare. Then how do we proceed to do a nerve block? So first, transducer selection, because we're going to do that with our ultrasound. It's the high-frequency linear transducer that you want because it's a superficial procedure, right? So it's in the superficial tissues. So with your linear transducer, you're good. Then you want to have your material with you. So what do you need? You're going to need to do some first. So either you have time and you anticipated your nerve block, so you have put some Maxilline on or lead or whatever topical anesthesia that you have in your department. Or if you don't, you can always use some of the Lido that you're going to use for your nerve block to just get a local anesthesia of the skin. You're going to need some anesthetic. So here at POCUS, we use mainly Lido, and then it's going to be with or without epi, and we'll discuss later why. In other departments or other hospitals, they might use different type of anesthetic, and we will go through a chart later with all the different ones that you can use. You're going to need a syringe for sure to put your anesthetic in. Usually here we use a connector so that the syringe is connected to the needle, and someone else, if you have enough people around you, either someone else is pushing the medication while the person doing the procedure is actually holding the needle. Everything by yourself. So you're going to need a needle. And then the needle, there is a bit of discussions about it. Some people say that we should use more kind of LP needle because then you do not hurt the nerve as much. But honestly, we shouldn't be touching the nerve. So it really doesn't matter. But you definitely want something that is long enough for you to reach. So LP needle are usually very long, so it's great. Or if you have other long needle, it's fine. Usually around 22 gauge is the one that you want, so kind of big. Prep the patient, so clean the area with either betadine or chlorhexidine or whatever you have. You want to be able to be sterile, so it's not a perfect sterile procedure. Like if it's not completely 100% sterile, it's okay, but still you want to try to be as sterile as possible. So sterile gloves on, sterile gel as well, and then something just to protect your probe. So you put the tegaderm on top of the probe so that the tegaderm is sterile on top of the probe that is touching the patient. And do not forget the little band-aid that you're going to need when you will be done, because it usually bleeds a little bit. So just have a band-aid with you.